Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I'm going to talk about antipsychotics for HIV primary care today. I don't have any conflicts of interest or relationships to disclose. I'm not going to use drug names even for the newer medications that are still on patent. I'm just going to use the generic for them. And then we do want to always recognize that data in this presentation offers a limited perspective on how systemic, social, and economic factors impact health, and it's racism and all other forms of prejudice that creates and perpetuates health disparities. So I have a poll question for everyone, just because I'm interested to know how many of you are managing antipsychotic medications. So 2/3, 63% roughly of you guys are managing your patients' antipsychotic medications, which is what I would figure from primary care. And it's increasingly primary care folks are managing these medications, which they're relatively safe, but they still do have a lot of side effects and things to really be considering as a primary care provider. Where do I see primary care providers, specifically HIV primary care providers, fitting in with antipsychotic management as a psychiatrist, right? So I think the big ones really right now are to think about the drug-drug interactions with ART. And unlike the antidepressant that we kind of talked about, there actually are a lot more interactions here. Biggest one really is the management of second generation antipsychotic cardiometabolic risk factors. That is unfortunately, we traded extrapyramidal symptoms, tardive dyskinesia, although that still happens with SGAs, but all of the really bad EPS that we were seeing with first generation, we traded all of that with metabolic syndrome and more heart risks. And then specific things, augmentation of antidepressants. I do think that while psychiatry is very scarce, it's good to have an understanding of how these medications can help augment for people with severe depression, treatment refractory depression, things like that. Talk a little bit about the management of behavioral and psychological symptoms in dementia, which is the off-label use that has a big black box warning. I think everyone gets a little bit afraid of that, and I certainly agonize over it myself. And then all of this kind of goes into co-management of severe mental illness, because unfortunately, there are not enough psychiatrists and psychiatric practitioners to go around, and so it does severe mental illness management does fall on primary care quite a bit, especially for people with HIV. So severe mental illness, this is really what we traditionally think of as people with psychotic disorders, schizophrenia and schizoaffective disorder, patients with bipolar disorder, patients with severe depression with psychotic features, or treatment-resistant depression where like you've gone the first, second, third line treatment and you're still not getting traction. And then other really mental illnesses that have severe functional impairments. So they're not a true definition. It's just if it has severe functional impairment, even a personality disorder can fall under the SMI category. Unfortunately, adults with severe mental illness are 4 to 10 times more likely to acquire HIV than the general population. And this was interesting, like a study in the late 90s out of New Jersey looked at New Jersey Medicaid recipients and found that 5.7% of people with HIV also suffered from schizophrenia. The national rates of schizophrenia in the general population is about 0.8 to 1%. It varies. So that's a significantly higher and disproportionate amount. So we do see these patients much more often. So individuals with severe mental illness are more likely than not to be prescribed antipsychotic medications. Obviously, if you have schizophrenia or schizoaffective disorder, you're likely to be on an antipsychotic. But even with bipolar disorder, the mainstay of mood stabilization treatment these days is really shifted towards the second generation antipsychotics. And many of the commonly used antipsychotics are CYP3A4 substrates and are therefore affected by our boosted regimen. And so that becomes a big thing to think about. Another thing that really kind of thinking about, and I see this on the consult service quite a bit, and it's kind of my like big hammer home point. So individuals with untreated HIV, and the data for this really does come about from the pre-ART regimen, However, it still stands during the kind of the modern period. Individuals with untreated HIV are 7 times more likely to develop extrapyramidal symptoms when exposed to antipsychotics compared to those without HIV. And really, when you think about that, the first generation antipsychotics, specifically haloperidol, are the big bad actors in this. Risperidone and paliperidone are kind of an intermediate between a first generation and a second generation antipsychotic in terms of their activity at the dopamine 2 receptor. And so I always kind of consider those first generation analogs. And then other SGAs, of course, are still going to have that effect. Even olanzapine, which we think about having very low EPS risk, you do have that risk in folks with untreated HIV. And so why does that happen? Well, HIV has a preference for the basal ganglia in the brain. And so if you have a lot of replication going on to the CNS, you already kind of have a risk factor for the development of subcortical movement disorders and subcortical dementias. And so we kind of are priming you to be hyper sensitive to that. And so when I'm on the consult service, if we're doing as needed medications for folks, I just, as a rule, like if you have HIV, I just steer away from first generation antipsychotics the best I can. Even if I know that you are treated, I just don't want to risk it. And we do have better ones out there. So we really try to avoid those first generations. And there's also other reasons, and we'll go into why we should avoid the first generations. And so antipsychotics of concern, Haldol. Haldol is used quite a bit in the hospital setting for agitation management, for people that are coming in that are just acting all whacked out, and we need to get them calmed down. And so Haldol is a very good antipsychotic for that. It has a lot of stopping power. It's also relatively clean, meaning it doesn't hit a bunch of other targets. It doesn't have this huge amount of drug-drug interactions. And so we use it quite a bit still here in the 2020s, despite the fact that Haldol was invented in the mid 1950s. It's still relatively good. But there are interactions with our HIV medications beyond just the concern of having EPS. And so we know that efavirenz will decrease the plasma concentration of haloperidol. That's less of a concern for me. Anything that decreases the plasma concentration of my medications, I can usually compensate for that, but it's something to know or to realize. And then our QT prolongation is really bad for this, especially with like atazanavir combinations. There's a really bad concern for folks having QT prolongation. And just as a kind of a reminder, the QT prolongation is the most concerning in IV haloperidol. IM haloperidol has a decent amount of it. And then the PO formulation, it's still there, but it's a lot less, obviously, than the IV and IM. The other thing to think about is that people who are agitated are more likely to have extrapyramidal symptoms. So you've already got a population that's more susceptible to this than if they're coming in agitated and you're giving them haloperidol. You're just setting them up for having some problems and it not necessarily being, you're having some iatrogenic effects from it. So I really do try to avoid haloperidol in this population the best I can. The other ones I really think about, I didn't include first generations. I just really try to avoid first generation antipsychotics in general in this population. And to a degree in my general population as well, because we have a lot better ones. We know that the rates of tardive dyskinesia and other symptoms are much higher for folks with first generations. So in our second generations, it's really the ones that are primarily 3A4 substrates. And we have a bunch of really good antipsychotics in this family, in this new generation. And unfortunately, some of the newest ones, the ones that have the best benefits, the better side effect profile, all are mainly 3A4 substrates, meaning anything with like a boosted regimen with like Cobi or ritonavir is going to ridiculously increase the levels of these medications. And they're just not safe in general to use unless you are just really, really comfortable and kind of understand how to potentially microdose some of these things. And then you also get some concern with the things that are kind of mixed 3A4 and 2D substrates. Aripiprazole and brexapiprazole They do have 2D6, but the majority of their metabolism is through 3A4. And where this really becomes a concern for me is anyone that's on a long-acting injectable who is also getting a boosted regimen, because the long-acting injectables stick around. So we're going to be increasing exposure risk. We're going to be kind of potentially making the side effects worse for a longer period of time. So tend to be really cautious with those and dose reduce as best we can for those folks. So why is this an issue? Well, I really, really like all 5 of these medications. They're kind of first line treatments for me. They're also kind of really coming in vogue, especially once some of these become generic. I think we're gonna be seeing more and more of these. So I've included here kind of the approved indication for these guys, and kind of thinking about also our QT prolongation risk and weight gain risk. And those are the 2 main side effects that I think about from a antipsychotic potential. So how much are we going to potentially prolong the QT interval, and how much weight are we going to cause you to gain? And so we think about aripiprazole being one of the most weight neutral of the antipsychotics. Ziprasidone is the most weight neutral, but on average, someone gains potentially half to a kilogram of weight on aripiprazole, which is not bad considering the other medications out there. It's also approved for use in pretty much everything. So schizophrenia, bipolar mania, bipolar maintenance. I don't actually, it's not approved for bipolar depression. That is incorrect, but it is approved as an adjunctive therapy for major depressive disorder. And I think it tends to be the antipsychotic that primary care folks are most comfortable using. It's relatively safe. Again, it's got a low cardiovascular risk profile. For the longest time, it was the only antipsychotic on the market that had almost no QT prolongation. So we really are using that quite a bit. But we also have cariprazine, which is a newer medication. It's seen some really astounding studies come out that the number needed to treat for bipolar depression is quite low. Bipolar depression is one of the hardest depressions to treat. And this new family of medicines, specifically cariprazine and lumateperone and lurasidone, do all seem to be quite beneficial for bipolar depression in a way that other medications in the past have not been. But they're all mainly 3A4 substrates, and we can't use them with boosted regimens for that. I will say the downside of lurasidone is it does require food administration. I always try to be avoiding medications that require food. It requires about 300 calories to get a proper absorption. And if you don't hit that 300 calorie mark, you lose 80% of the bioavailability of the medication. So that tends to be one of the things that limits how much lurasidone I prescribe, though it is really good for bipolar depression for lots of people. And then quetiapine, I think quetiapine is probably the other one that primary care providers are most familiar with and comfortable with, either on the internal medicine side of the service, for the hospital side of the service. For our geriatric population with dementia, it tends to be the safest in dementia with behavioral disturbance. Again, it is primarily a 3A4 substrate, and so we have to be really careful with that on here. So definitely considering these, using our Liverpool calculator to make sure that we're not causing problems. The other thing that we want to think about, especially as primary care doctors, is this preventative care for individuals who are on antipsychotics. So this comes from the NICE guidelines in Great Britain. So anyone that's on an antipsychotic is supposed to have an annual review of these topics. And when I'm seeing patients who are on I'm always kind of looking at this, but anything to help mitigating cardiometabolic syndrome is really the most important thing we can do. And so really, of course, working on getting alcohol consumption down, making sure people are not drinking at heavy levels, if we could, just not drinking at all. Smoking cessation. People with schizophrenia have a much higher rate of smoking. There's some interesting pharmacology there, but we know that people with schizophrenia smoke quite a bit more. And so if we can get smoking cessation down, get people to stop smoking, that's going to be one of the best things we can do. Monitoring weight, monitoring blood pressure, and monitoring glucose and lipids are all really, really important as well. And so when we think about monitoring, what are the monitoring parameters for this? I really like working in an HIV psychiatry setting is because HIV patients are already getting most of what I want anyway. And so really, when we're thinking about these, when we're starting at a baseline, we really want to get baseline weights. We know that weight gain with antipsychotics occurs mostly within the first 6 weeks, but will tend to continue, especially with olanzapine and quetiapine, it'll continue going up and max out over the course of about 6 months. With some of the other ones that tend to be a little bit more weight neutral, quote unquote, it tends to max. You tend to get the weight gain within the first couple of weeks to 6 weeks. You hit the max on there. So you really want to be monitoring weight. I will tell you the monitoring weight on a monthly basis for 8 and 12 weeks is something even in psychiatry we're very bad at doing, and it's something that we should be trying to do quite a bit more. Getting a waist circumference as a proxy of body fat composition is a really good thing. And again, I don't do this regularly and I need to work on it as a better thing. But what I do quite a bit is blood pressure, heart rate, and our labs, like a fasting glucose, a fasting lipid, getting those as well as CBCs on patients regularly. We should be getting EKGs on all of our patients who are starting on an antipsychotic. You could argue that aripiprazole, cariprazine, lorazepam, lumaptoprone, those don't have not a lot of documentation of having QT prolongation or torsades de pointe. There's only a couple of instances of TDP for people with aripiprazole. They don't think that it was related to the aripiprazole. They had a lot of other cardiac factors that were driving it. But I get EKGs on everyone, even if it's a low risk medication. The other one that's not necessarily in the US guidelines, it's more in the European guidelines, is getting serum prolactins on some of our more high-risk medications, meaning the ones that are the most dopaminergic, the first generations like Haldol, the second generations like risperidone or paliperidone, getting a baseline serum prolactin, because you know that those medications will increase prolactin quite a bit. And long-term, the serum prolactin is a fairly silent thing. You're not going to see immediate effects, but over the long term, you do get things like gynecomastia, bone demineralization, things like that. So we should be trying to monitor that. It's also a reason to kind of stay away from the bad actors if you can. Downside of that is paliperidone tends to be one of the better long-acting injectables. So anyone that is on paliperidone, I usually get the serum prolactin level, and you really only need to do it like annually afterwards. And then CBC is important. We think about clozapine as being like that's the one we get hammered home in medical school for neutropenia and agranulocytosis risk, which is a very real thing. I did induce that in a patient recently and had to stop the clozapine. But all of our second generation antipsychotics, as well as some of the first generation antipsychotics, have the risk of neutropenia and agranulocytosis. It's a lot lower than clozapine, but it's certainly there, and it's certainly something that we need to be looking out for. And so a CBC is indicated in these folks. And then the other one that I really think about is an abnormal involuntary movement scale, which that is the AIMS. It is online. All antipsychotics, except for clozapine, low doses of Seroquel, and a new one called pimavanserin, which was for Parkinson's-induced psychotic disorder. But all of the other ones have risk of EPS. They all have potential for tardive dyskinesia. And so even though we think about it with the first generation antipsychotics, really we need to be watching out for everyone. And so an AIMS or some other musculoskeletal exam that looks for telltale signs of dystonias, tardive dyskinesia, akathisia, things like that need to be done. And so it's really, that baseline, that first 12 weeks, and then annually thereafter. And this is not something that is routinely done either in psychiatry, because technically it's not in our guidelines, or in primary care, but it's a deficiency in our guidelines. And I think it's actually a pretty sad deficiency, because we do know that second generation antipsychotics do have movement disorders, even though it's not at the rate of a first generation. think about the weight gain potential, and this again is the reason why I think it's important with, especially with our boosted regimens, because the medications that have some of the least amount of weight gain are the ones that have the most interaction with a boosted regimen. So things like aripiprazole, which has only about a kilogram of a weight gain within the kind of, it doesn't really cross into statistically significant for in a lot of studies. But cariprazine, which is not on here, lorazepam, it's pretty low. All of the newer medications that have been coming out all tend to be really good for preventing weight gain. Whereas olanzapine, I'm going to make you gain a whole bunch of weight. The average is about 4.15 kilos. I've seen 30 and 60-pound weight gains. It's not uncommon to happen. And so that also brings up another kind of thing, is that oftentimes primary care is the first point of contact with a patient who's coming out of a hospitalization for a psychiatric issue. And a lot of times they have been put on olanzapine because it's quick, it's effective, and it works really, really, really well for our psychotic illnesses. But I do make people gain quite a bit of weight with it. And so how do we manage the antipsychotic weight gain? And I think that's the biggest thing that we, as primary care doctors, as well as psychiatrists, need to collaborate more on. So non-pharmacologic treatment actually is quite effective. Things like cognitive behavioral interventions, nutritional counseling, nutritional interventions, and exercise programs have all been shown to be both beneficial in treating weight loss as well as preventing weight gain with antipsychotics. And the average weight loss from folks who'd already gained weight in pretty large meta-analysis was about 2.5 kilograms, which, if we think about it, olanzapine is around 4 kilograms. You can prevent them from gaining about half of the weight, which is not an insignificant amount of change. So definitely something we all should be promoting. The other thing that I do quite a bit is, okay, we got you calmed down, we've got you stabilized on the olanzapine. Now we need to switch it to something that's probably in the best interest for you, that doesn't have this horrible weight gain potential. The one that has the best evidence for switching to really does seem to be aripiprazole in terms of reversing weight gain, reversing some of the other deleterious effects of the antipsychotic. It's not quite as effective as some of the other medications out there. It's certainly not as effective as olanzapine in treating all the symptoms of psychosis, or treating a lot of the psychotic features of bipolar disorder, but it's better than olanzapine in general. And kind of the nice thing is it plays well with olanzapine. So that there's a study that looked at what we call rational polypharmacy with antipsychotics. And you look at it, and the biggest one that showed the best evidence for both augmentation and treatment of negative side effects of the olanzapine is the use of aripiprazole. So I try to get people on aripiprazole as quickly as I can. If not, lorazepam, cariprazine, and lamaptoprone all have much more favorable weight gain potentials. Ziprasidone is also consistently shown to have the lowest weight gain potential of all the second generation antipsychotics. I do not like ziprasidone because it requires about 500 calories of food, and it's oftentimes dosed twice a day. So it's really, really difficult to get people to take ziprasidone. It's also just not the greatest in terms of treatment of anything other than schizophrenia. It doesn't do the greatest in bipolar disorder. It definitely doesn't do good as an augmentation strategy for depression. So the other thing I oftentimes look at, and this is the conversation I have with lots of people who are coming out of the psychiatric hospital, is if you are on olanzapine, we need to make sure that we are mitigating your weight gain potential early. And the best way to do that, honestly, that's been shown, is augmenting with metformin. So metformin is very protective. It is recommended in our guidelines that anyone that's on a pene, so meaning olanzapine, quetiapine, clozapine, be started on metformin. Typically 500 BID is an effective dose for it. But if people have already developed weight gain, you can lose about 3.3 kilograms on average. It does definitely work better in terms of prevention. And so people who are started on that early will not gain nearly as much weight as they would if they were not on it. Naltrexone is a little controversial. Some of the studies are really poorly designed. Some of them have shown that it's helpful. Some of them have not shown that it's helpful. But it was such that there is a cousin of naltrexone called samidorphan, and this is now a combination product that is FDA approved in 2021. It's olanzapine and samidorphan. There's really no difference between samidorphan and naltrexone. In theory, samidorphan is a little bit more potent at the mu-opioid receptor, but it was an orphan drug that they adopted and they found it. But the studies have been pretty good that it does prevent as much weight gain. Roughly half, you'll gain roughly about half the amount that you would be expected to otherwise. The downside of this is that the combination product is really new, really expensive. And so I do offer naltrexone to people who are on olanzapine. It's kind of a menu of options for folks. And then we know, like I said, adding aripiprazole to olanzapine, even without the intent to stop the olanzapine, can cause weight loss and help with the dyslipidemia. Topiramate has got some promise to it. I don't like topiramate because its cognitive side effects tends to worsen negative symptoms of schizophrenia. So I tend to steer away from it if I can. And then, of course, we all love the GLP-1 agonist. The data for it's promising, but there's such small studies. There's not really a lot of data out there right now. So I think we kind of have to hold off on that. Certainly, if you have diabetes, you have obesity, it is a reasonable thing to use the GLP-1 agonist, but just for the prevention of it, not entirely sure. It's going to be a hard sell to a lot of insurance companies to use GLP-1 right now for antipsychotic weight gain. So the other place that you're going to do likely a lot of this is an antidepressant augmentation. So certain antipsychotics do have an additional antidepressant effect, and then they improve residual symptoms of depression. This is not the treatment of psychotic depression. So psychotic depression is a different subject altogether. This is just people with kind of lingering depression. It's not getting better. And how do we help? And can we add something? And so the four medications that are really out there that have the most evidence for this are aripiprazole, to a lesser extent, its cousin brexapiprazole, quetiapine. Quetiapine XR really is the one that has the best benefit from it. Quetiapine IR doesn't seem to have quite the amount of oomph as the XR formulation for depression and bipolar depression. Cariprazine, like I said, has been really kind of an amazing product lately. I don't get any money from that company whatsoever, but I do think about this as an option to go to because the data is so good right now. And then this combination of olanzapine and fluoxetine, which is a single kind of pill combination. Downside of that is weight gain. And I really stay away from olanzapine fluoxetine combination, for antidepressant augmentation. My kind of go-tos are aripiprazole, quetiapine, and cariprazine. And really, I go with aripiprazole. And that's because it's been studied for the past 20 years. Looking at this, we don't really need to go to a high dose of this. So this was an early study that kind of looked at treatment response to low dose versus a standard dose, which is 10 milligrams. Certainly the 10 milligrams has a quicker response rate, but unfortunately the dropout rate in the studies have always been much higher because the akathisia risk with 10 milligrams is so much higher. So I really worry about akathisia with aripiprazole. So I kind of have this conversation with people. I'm like, I can get you better within 3 weeks and not give you a lot of side effects by starting at 2.5. So I tend to start at 2.5, maybe go up to 5, but you still get pretty good efficacy at the low dose without the risk of EPS. So behavioral and psychological symptoms of dementia and antipsychotics is extremely controversial. We know that we have the increased risk of mortality in elderly patients with dementia, but yet we still are prescribing antipsychotics. Why is that? It's because the behavioral symptoms of dementia are so distressing both to patients and families. Antipsychotics are quite quick to work, and so we use them quite a bit. But we do have to understand that they all carry a mortality risk, especially for things like cerebrovascular events. And so we got to be really, really careful with them. When you look at it, though, it does seem to favor using quetiapine for this population. Quetiapine at low doses has a negligible hazard ratio for increasing all-cause mortality for patients with dementia. Haldol, you will kill your patient. It is like, don't give them Haldol, don't give them risperidone, don't give them olanzapine. But for the behavioral effects of dementia, quetiapine likely is the safest option. The indications for that are severe aggression, severe agitation associated with for harms, delusions and psychosis, or obviously if someone has schizophrenia, don't yank them off. Now that they have dementia, don't yank them off their antipsychotic. And usually like kind of inappropriate shouting, pacing, touching, those aren't really response. So we're really looking at agitation, aggression, hallucinations as the kind of the first line treatment. We never use first generation antipsychotics. We always want to use the lowest dose possible, document the behaviors that we're targeting, and then reviewing every 3 months and trying to taper if we can.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.